I get to introduce myself today. So I'd like to introduce Dr. Van Tassell. He is a fantastic faculty member in the VCU School of Pharmacy, influences the lives of millions, the most modest guy I've ever met. Anyway, so this is fun. This is something that has been a long time coming. This is not really today. Today I don't get to present my own research. This is almost more of a journal club type format where we're going to talk about some research that was done by some other folks, not really affiliated with VCU, but it's the kind of, I hesitate to oversell it, but it's kind of a landmark study that really has been, I would say this has been years and years in building this is maybe the best, spoiler, this is maybe the best we've ever done as a profession of really capturing the impact of what a pharmacy group can do in a very treatment-resistant and difficult population. So when this came out, this was during the ACC meeting in March, and it was on ACC's, I think, a 3 or 4 day event, and this was the 4th day. This was like the last presentation at like one of the last sessions of the late-breaking trials, and so I missed it. I didn't stick around for the very last meeting, and it's kind of one of those life lessons, like don't leave before the end of the meeting because you might miss the most important study to come out of that meeting. And I think Twitter, thanks in no small part to Dr. Dixon's activity, picked up on this one immediately and said, hey guys, this may have been the most important study to have been presented in 2018 as it relates to cardiology. So with that buildup, it's my pleasure to kind of review this for you. So hypertension is a big deal. If you want to look at leading causes of death in this country, these are the most recent data that we have from the CDC. You can fairly directly attribute about 30% of the current mortality that we have in this country to hypertension or hypertensive causes. I think as a fairly well-educated and healthcare-focused group, I don't need to spend too much time here. Definitions of hypertension. This has become a little bit of a game over the last few years. We've changed up the definitions of hypertension. If I remember JNC 7, these definitions came out like the month after I finished my cardiovascular module in pharmacy school. So I was a P2 back in 2003. And these are the definitions that we lived with for 14 years. So hypertension really is kind of on the uptake starting around, can I get my mouse right here? Yeah, starting around 140 over 90. And so the treatment goals were designed to get folks to less than 140 over 90. Now, just late last year, less than a year ago, we had an update. Now, if you think the actual name for the JNC 7 committee was long, the 7th report of the Joint National Committee on Prevention, Detection, Evaluation, and Treatment of High Blood Pressure, we made the name even longer. So nobody even uses the name anymore. It's just the 2017 guidelines for hypertension. And you can see that the biggest difference is kind of in this mid-range. What used to be kind of put into this pre-hypertensive range that nobody really knows what pre-hypertension means. It was kind of a made-up term just for those guidelines. But it took that pre-hypertensive stage and kind of divided it. So if you're 120 to 129 systolic, that's elevated. But stage 1, as you may have heard in the lay press or in your own readings, stage 1 now starts at a systolic of 130 and goes up from there. So we kind of tightened up the treatment goals for patients, and this is going to become particularly relevant when we look at the way that the treatments were designed in this study. So this guideline actually came out well after the study was conducted, but I think it highlights some of the differences in how we're treating hypertension today. So what about the benefits of treatment? Hypertension is one of those diseases that is highly prevalent. It has incredible impact on morbidity and mortality, but it's also treatable. Treatment works. We have drugs that will get blood pressure down and have an enormous impact on these outcomes that we think are important. You can reduce stroke, MI, heart failure, kidney disease isn't on this graph, but you can do amazing things by getting the blood pressure down. And if you really want to geek out on the details, there are plenty of disease states where bringing the blood pressure down makes a difference. Whether you're talking about angina, MI, heart failure, TIAs, stroke, PAD, aortic aneurysm, all of these are major disease states in this country that are sensitive to blood pressure reduction. So if we have a disease state that is highly prevalent, has high morbidity and mortality, has excellent treatment options, this ought to be something that we're just knocking out of the park. This should be low-hanging fruit. Everybody should have their blood pressure easily detected and treated, and we should wipe out heart disease. Turns out that doesn't happen. Turns out we actually struggle immensely to do this. And there's not a great reason that we can point to that says, why are we so bad at taking care of hypertension? On paper, we should be excellent at this. On paper, this should be fairly straightforward. The blood pressure's up, put them on an evidence-based medicine, bring the blood pressure down, and you fixed it. But it doesn't play out that way. So there are a bunch of different ways to slice up the data. But even in our best case scenario, if you look at our female population between the ages of 40 and 60, we're almost up to 2/3 of patients at goal. And that's best case scenario. If you look at these crazy guys, 18 to 39, what's wrong with this guy? Is it the patient's fault? Is it the provider's fault? I don't know, but only a quarter of patients are treated appropriately. I don't think any of these look great. Right? I think all of these are really representing a system failure on our part. Gets even, I don't know, maybe even a little more interesting if you want to look at it by racial subgroups. So as you might expect, it's the non-Hispanic white population that seems to have the best response to treatment. Now, most of the studies that we do to treat high blood pressure are done in this population. If you look at any blood pressure study, it's enriched generally with white males. So go figure, the treatments work the best in white males. When you start looking at other populations, other populations don't typically respond as well to our conventional treatments. So if we're doing a poor job in general, we're even poorer, we're even worse at treating some of these minority subgroups. And stop me at any point in time if you want to chat about something or something jumps out at you from the figures. All right. So digging a little deeper into that, if you want to talk about where hypertension is the biggest problem, sorry, it's a little fuzzy there, but there's some trends on the map, right? Don't always need statistics to infer things from pictures here, but so clearly the answer, and this is what we tell our pharmacy students, is if you live in the South and you have hypertension, you should move to Montana. Right? That's what we need to do, right? Well, correlation isn't always causation. And I do want to point out that it's not that blood pressure, hypertension has been cured in Montana. You can see the figure here. It's still 25%. It's not like it goes down to zero. It's still a quarter of the population. And actually the spread on these numbers is not that great, right? These are just quintiles. So it goes from 25% up to 39%. So it's everywhere. If you want to break down deaths by county, maybe you can use this to start picking up on some clues, but one of the things that has been reported again and again and again is that in the African-American male population, which, not surprisingly tracks pretty well with this graph, that's where we're doing the poorest job of preventing heart disease deaths. And so that's really the backdrop for this current study. So this is a study, this is the New England Journal kind of figurehead. So it's a cluster-randomized trial of blood pressure reduction in Black barbershops. So what do they do? So this is a cluster-randomized trial. I will admit I've never done a cluster-randomized trial. Basically what we're talking about here is the centers themselves were randomized to the intervention group or control. It wasn't that they were randomizing patients at each individual location, but center 1 gets the intervention, center 2 gets the control group. Now that's, as you think about that, as you chew on that a little bit, that may introduce some potential biases that you wouldn't get in a classically randomized controlled trial. But for a lot of these intervention studies, you'll see the cluster randomized model because it's very difficult to maintain allocation concealment when you're doing 2 different treatment models at the same center. And it kind of creates some awkward I mean, again, it might create some awkward person-to-person interactions where a patient, you're like, all right, Dr. Dixon, your appointment, but, oh, no, you go to this room, and, the next patient, Dr. Carroll, you get to come see our specialist. It's awkward to do in a single center. So for a lot of reasons, I think that's why you see this cluster randomized model for some of these implementation sciences. So I think one of the biggest consequences of that is that it is completely non-blinded. Everybody participating knows which is their group. Okay. So are there some concerns from that? Yeah, and if your spidey senses are tingling, that's a good thing. All right, so they did adjust for some covariates, baseline blood pressure, routine access to physician care, and high cholesterol. As far as I can tell, these first two were specified a priori. This one just kind of came out in the data. When they looked at the groups, they found that there was an imbalance in the baseline cholesterol. And actually, the treatment group had more high cholesterol to start with. So how do they go about doing this? The screening, to account for, I think, from my perspective, to account for this lack of blinding, they actually brought in independent folks to do the screening and enrollment. So these were contracted professional interviewers that would come to the different barbershops. They would obtain informed consent, and they would do the screening. They would do the baseline interviews to collect all of the data. So they were looking for non-Hispanic Black men, and they had to be regular patrons. So at least one haircut every 6 weeks for at least 6 months. So, and they mentioned that this was being done to, again, try to find a cohort that had a good relationship, that found the barbershop to be a place of trust for them. And I think as we talk about how we might be able to implement some of this stuff, that's a key factor. I don't know that there's anything magical about the barbershop, but there might be something magical about the barber-client relationship that we might be able to mimic. Age 35 to 79, and you can see here the systolic blood pressure they had to have on 2 separate occasions. Women dialysis and active chemotherapy were the only listed exclusion criteria. But this is a direct quote from the paper. It says, participants and field interviewers were aware of the randomization assignment of the barbershop. So ask yourself how you think that might have potentially impacted the results. So what was the actual intervention? The intervention had a lot of moving pieces, so I tried to simplify it here. Both groups had barbers, right? They were both in barbershops. And in both groups, the barbers were encouraged to encourage the patients to seek out care. So maybe we'll start with the control group. So in the control group, they actually trained the barbers to encourage lifestyle modifications and doctor appointments. This, I think you can make a fair argument that this is kind of our standard of care. Maybe this is even a little bit better than what you would expect when you go to a barbershop, right? That you're going to your barber and they're saying, hey, how's your blood pressure doing? Are you doing your lifestyle modifications? To go see your doctor. This is, would we expect these patients to perform better than standard of care? Maybe, I don't know. Norm?
Did the people in the control group know that there was an intervention group? Or were they just sort of thought they were in the study? And
I don't know the answer to that. So that way that gets to the implementation, right? That when they were signing the consent, did their consent say, hey, this center we just want to evaluate the effect of barbers encouraging lifestyle modifications, or were they explicit? I don't know.
It seems like that would, if they didn't know there was the other group, that would alleviate or lessen some of the
problems. No, I think that's a great point. If you could hear that, if they were even somewhat blinded from the presence of that other arm, that might make it a better control group. The prior statement that I had up there, it said the interviewers, they were certainly aware of the allocation. If I had to guess, and I have to look into this, my guess is they did know. But Mary, please.
Well, I'm just asking from your IRB perspective, because you're very active in the IRB, would you ever let the control group not know what an intervention group was? I would just think that you would have to say this is what the study in total is looking at, and you are randomized to one group, right? Like I don't. It doesn't seem like it's very informed. if you don't tell them.
That's the default pathway. There are conditions where you could get, it would actually fit under the deception rules. So you can do human subjects research that involves deception, and even withholding information counts as deception.
But this
I suspect that that's
like
not what they did.
Yeah,
I
this
suspect
wouldn't
that
seem
this
like
was
an instance where
overt.
deception rule would. I mean, you know this.
I suspect that everybody knew. I suspect that everybody knew, but I don't have the consents. There is a movement now with some of these medical journals to say, hey, if you're doing human subjects research, let's publish the consent along with the paper, and that would answer the question. But I don't know. It's a fair question. So the control group, that was about it. And I will say, participants in both groups did also receive some cohort retention tools. So everybody got the results of their blood pressure screening. They got a little card. It's in the supplementary material. You can look at, here's your card, here's your blood pressure. They got a follow-up call at 3 months, culturally specific health sessions, and vouchers for monthly haircuts. Okay, so that's a control group. So the barbers, the intervention group. So the barbers here, they promoted follow-up with specialty trained pharmacists. There were 2 pharmacists that were involved in this study. And these 2 pharmacists had to go through, and they had to do they had to become a certified hypertension clinician in the American Society of Hypertension. So they had to go through a validated training system so they could take care of these patients. Now the barbers were trained to measure blood pressure as well. And in some of the centers, the barbers would actually measure blood pressure if the pharmacists weren't there. They could still measure the blood pressure and take care of the patients that way. So maybe that's tipping the playing field just a little bit. Now, the actual pharmacist interventions, these pharmacists met regularly with the participants. They could prescribe medication through a collaborative practice agreement. They also encouraged lifestyle changes, just like the barbers. They assessed the blood pressure changes at follow-up. They could actually do point-of-care laboratory testing to look at metabolic panels. They also sent regular progress notes to providers, and they gave out $25 vouchers. Okay, so this was the entirety of the model, and maybe after we've gone through the results, I kind of put this slide back in at the end because I think we need to spend time here. This intervention worked, but when we say that it works, the larger question is, I think, why did it work? How did it work? What do we take from this? We have to be careful that which one of these aspects of it was it that made the difference? Was it all of them combined? Was it 1 or 2 of these elements that kind of dominated this effect? We don't know. I mean, this is the first step with this. This is just a snapshot that we have of the intervention. Yeah, Julie?
I'm curious if you mentioned CPA and prescribing medication, whether that was they could initiate new medications, change the dose, just refill.
All of those.
Okay.
Yep. So they were very explicit. They were prescribing the medication. So they were prescribing the medication. There was a script for them to follow. They encouraged them, I think it's on one of the next couple of slides, they encouraged them to start with a amlodipine ACE ARB combo. Those are kind of your first 2. You kind of pick between those. Then with indapamide as a 3rd-line drug. So it was, but yeah, they were there taking care of the patients. Now, interesting that each patient had the collaborative practice agreement signed by their own physician. So there wasn't like a general physician that served as the provider for all of this. They really wanted to tie things back to their regular providers. So as part of this process, you had to get your own physician to sign off on the practice agreement. In a few cases, if they couldn't find one, they did provide one, but it was designed to kind of shuttle things through their primary care. All right, blood pressure assessment. They used state-of-the-art automated cuff where the results of the patient didn't get to see what their results were, just recorded it. So the patient didn't get nervous about it, didn't get worked up. They had to do the 5 minutes of rest, the arm resting. They couldn't be talking to the investigators at the time of the reading. They measured it 5 times. Right, that's a lot. First 2 are thrown out, and they averaged the last 3. In order to be in the study, you had to have true hypertension above 140/90. So they're using the JMC7 definitions. and had that on 2 separate occasions. And if you had it on 2 separate occasions, only your second occasion blood pressure is used as the baseline. And this is a picture of the monitor. I've actually never used one of these. Has anybody used one of these? These are expensive. They run for like $5,000 on Amazon. I'm not sure what makes them so fancy, but they look cool. All right. Okay, so the antihypertensive protocol. This was only in the intervention group. The control group got no blood pressure management protocol. They were just encouraged to see their regular doctors. So the blood pressure goal for these folks was set at 130/80. Okay, more of a 2017 guideline type approach. And they started with amlodipine plus the ACE-ARB. So this is again, if you're trying to stack up the points of potential criticism for this study, targeting a blood pressure of less than 130/80, is that really the same target that they were getting in the control group? Probably not. So again, to what do we attribute the benefit of this intervention? Was it the pharmacist? Was it the setting? Was it the follow-up? Was it the drugs used? Was it the blood pressure target? Unfortunately, there were a lot of things that were different between the groups. Well, fortunately for the patients, there were a lot of things different between the groups, right? So all of these things added up, to give us the benefit that we saw. This is a little picture of the handheld point-of-care testing. I've also never used one of these. Has anybody used a handheld one of these? Dave? Yeah? Okay. These are also fairly expensive, but this will give you metabolic panels, point of care. So all of the blood testing was done in the barbershop. If they needed to monitor renal function and potassium levels, they did it with one of these handheld devices there in the barbershop. Primary outcome was specified as systolic blood pressure. They also looked at the things you might expect: diastolic, the percent of patients at goal, number of meds, adverse drug reactions. They even got into self-related health and patient engagement. And they used AKI criteria that are pretty standard. Now, unfortunately, we don't have data on laboratory adverse effects in the control group, because the control group didn't get any real extra laboratory testing. So all we have for electrolyte changes come from just the intervention group. Questions so far on the methods? Does this kind of make sense?
So how many pharmacists do they have, and how many barbershops, and how do they coordinate? 2 pharmacists.
2 pharmacists.
And so would they schedule, the patients depending on which barbershop they were going to, or did they just do there for like a morning?
I can only imagine.
Okay.
Yeah, I don't have a great answer to that. Does anybody else? Sean, you were in Southern California around this time, right? Or this was more in LA, not San Diego, right?
LA.
Yeah, okay.
Cedars-Sinai Medical Center, I think.
Okay. Yeah, so I don't know exactly how they managed it, but that was one of the things that struck me, is like, wow, there were close to like 120-something patients in the active treatment group and only 2 pharmacists. So yeah, I think scheduling may have been tricky, but I don't quite know how they did that. I had to read it 3 times to say, are there really just 2 pharmacists doing all this? And, like, really? But it seems like, yeah, really. So one of the other things they did in the intervention group is they put these kind of patient testimonials up on the walls in the barbershops, just to encourage the good behavior. You can see here's one of the patients. This is a guy that had been really going after it, trying to lose some weight, but his blood pressure kept going up. Eventually, his barber introduced me to the pharmacist that worked with him. So I'm guessing this one is Kathy. But, so Kathy prescribed my medicine. My doctor's on board. I'm glad, because I want to enjoy life at 70. And you can see here's their fancy, little blood pressure machine there. All right. So what did they find? Sorry, I know this is a little bit tricky to read through, but things to point out. 4,500 barbershop patrons were eligible for screening. So a lot, you can say the vast majority were not eligible, right? So most of them had problems just because their blood pressure was not, their blood pressure was not high enough to participate. As you kind of work your way through to those who actually were included in the analysis, you had 139 that were uncontrolled hypertension in the barbershop group, or in the intervention group, and 180 in the control group. The retention rates were fantastic. Over 90% of patients were retained throughout the study. In terms of the baseline characteristics, you can see there were 28 barbershops in the intervention group, 24 barbershops in the control group. I don't want to spend too much time on this, but just to give us a sense for kind of who these patients are, about 54 years old. 3/4 already had some regular medical care provider. And if you want to look at traditional cardiovascular risk factors, BMI about 31, so these are overweight patients on average. About 1/3 were smokers, 20% with diabetes. And you can see here, this is the one area where there was a significant difference in baseline parameters. 35% of the intervention group versus 24% of the control group had high cholesterol. So all in all, a fairly standard urban patient cohort. All right, so here are the blood pressure results. They have them actually kind of mapped out by cluster here. But basically, we're talking about a group that had a baseline blood pressure around 150. And you can see at 6 months, that has been dropped to somewhere in the 120s. In the control group, a similar baseline, not as dramatic of a result. And I think it probably makes sense to go ahead and just look at the results this way. So in the intervention group, there was a reduction in blood pressure of 27 millimeters. This is the largest I've ever seen. I'm not aware of a study that has done this. It's kind of cool. Just if that's the only thing that came out of this, this is an incredible reduction, 27 millimeters of mercury on average among these patients. You can see that the control group, there was still some benefit. I mean, maybe that's regression to the mean. Maybe that's just the benefit of having this increased awareness from participating in a study. And maybe the guy down the street at the barbershop is getting a pharmacist, so you're going to take care of yourself. You're going to do a little bit better. I don't know. Even when you do, when you kind of subtract out the intervention minus the control, the intervention effect is still pushing 22 millimeters of mercury. That's as high as you'll ever see. Even in like the sprint trial, this is better than that. This is impressive blood pressure reduction, sustained over 6 months. We just don't see this magnitude of reduction in our clinical trials. You can see the diastolic changes were maybe even more impressive to get 17 millimeters of diastolic blood pressure. Again, in our younger patients, and 51 is kind of a younger patient as far as a lot of blood pressure studies go. It's the diastolic blood pressure that is driving a lot of the disease state and is maybe more resistant to changes with medication. So this is the biggest diastolic blood pressure reduction I've ever seen in this study. So this works. We can quarrel about what it was in the intervention that caused all this, but this worked. This was amazing in terms of blood pressure reduction. If you want to look at the percentage of patients at goal, 89%. Now I'm happy, right? This wasn't, getting 2/3 of patients to goal, best case scenario. This is 90% of patients getting to goal. And you can see in the control group, it was about 32%. You remember our control rates in African-American men from the beginning? Yeah, this is about what you see. So maybe this is evidence to suggest that this was a pretty reasonable control group. So to go from 30% at goal to 90% at goal, that's fantastic. This is why there was all of the coverage of this study as maybe the most significant study in cardiology in the year 2018. So this is impressive. This is great. And if you want to even say, okay, what if we look at the 2017 guidelines? It would put the blood pressure goal for these folks at 130/80. Okay, yeah, we're not having as many there. It's 2/3 of patients, but look at the comparison in the control group. Only 10% are getting to goal with standard care versus 64%. So it's a mammoth blood pressure reduction. This is as good as we can do, as good as we've ever done. What about the number of blood pressure medications? Were we just throwing all kinds of meds at these patients? No, we're pharmacists, right? We're well-trained clinical pharmacists. We're judicious in how we use medicines. We're using the right medicine for the right patients. And you look at 2.6 medications per patient versus 1.4. Apparently, when you do the paired analysis, I haven't been able to reproduce this math of 1.9, but maybe somewhere, I thought, is this maybe, it says it's a relative risk. I'm wondering, is 2.6 90% greater than 1.4? No, it's not. It's not quite apparent what that 1.9 represents, but I think I understand 2.6 and 1.4. So, about a medication or two more in these patients, but it's not like they were getting all the medicine in the world thrown at them. And as you can see, they adhere to the protocol fairly well. The ACE/ARB calcium channel blocker, almost all the patients in the intervention group were on those, versus kind of a mixed profile in the control group. Kind of fairly representative of standard care, where all three of these medications would be considered generally first line in this patient population. Now, why did they choose the ACE/ARB calcium channel blocker combination as kind of their first line approach? Well, the only two-drug combination study that's ever really been done suggested that ACE calcium channel blocker was better than ACE thiazide. So that's the accomplished trial. It's not one that we talk about a lot, but there was an evidence base to using this approach. I should talk about those drugs too. All right. What about the adverse reactions? If we had this great efficacy, what was the cost? What was the risk of doing this? Now, this is buried in the supplemental table. It's one of the only blood pressure studies I've ever seen that doesn't even have the adverse effects in the main paper. Found it. Supplementary table 5, you can see that there were some changes in adverse effects, but surprisingly enough, there was a reduction in some effects by using in the intervention group. So you got less gout, less difficulty breathing in the intervention group. Any guesses as to why that may have happened? Why would you expect less gout in the intervention group? Go back to the meds, right? They're actually using more diuretics, but they got less gout. I don't understand that one.
Using losartan as their ARB, which has been shown to be helpful as well.
Okay. So I don't quite know what to make out of that, but it's nice that they didn't see a dramatic increase in these adverse events. So less gout, less difficulty breathing. There was an increase in erectile dysfunction and dizziness. Okay, so it wasn't that they were free of adverse effects, but these were the closest, these are the only adverse effects actually described in the manuscript. They were the ones with the p-values that suggested that there might be something going on, but officially, the only changes that they saw in adverse effects was a reduction in gout and difficulty breathing or wheezing. So all in all, this seemed generally safe. I'm not sure that we have enough numbers here to get a true assessment of the safety of this approach, but we have to say that there weren't too many concerns from a safety standpoint. The acute kidney injury, again, they only can measure this in the intervention group. There were 3 patients that developed acute kidney injury by those serum creatinine criteria, and it completely resolved in all 3 patients, and there were no long-term consequences. So remarkably safe treatment. All right. So what are the strengths of this? Number 1, it's the blood pressure reduction. With all of the potential concerns about this study, this should be in all caps, right? I mean, have I made my point here? This is huge. This is an incredible blood pressure reduction. Community-based intervention. I love that. It was, the authors talked a lot about the convenience factor, but that was really driving the way they put this together, is to make this convenient. Take the treatments to the patients. I think that's a huge key to why this worked. It was sustained over 6 months. The retention rate of 90-something%, that's crazy. We never see that. Why do we see in this study? Again, maybe they were kind of selective about who they let in. It had to be somebody that already had an established relationship with your provider, with your barber provider. Right? We talked about convenience and few adverse effects. And yeah, if you want to pat yourself on the back as a pharmacist, pat yourself on the back. This looks good for us. this is a profound demonstration of what physician-pharmacist collaboration can do. That's exciting. I think that's a huge win for the profession, but more importantly, for our patients and our physician colleagues. All right, limitations. Anybody concerned about the lack of blinding? Well, let's talk through this. How might the lack of blinding diminish your confidence in these results? Why would the lack of blinding have contributed to inflated blood pressure reduction in the intervention group? Do you think that's an issue?
Patients in the intervention group were more motivated because they knew they were assigned to an intervention group.
Right, you know you're in that intervention group. There's that observation bias, right, that could occur. What else?
I would also think that you might, if you've been going to your barbershop for years, you've got a sense of community at your shop, and the whole shop is trying to do a great job at reducing their blood pressure, so it contributes to like a really positive atmosphere. Which
is kind of a cool thing to create, right? We've created this positive snowball of emotion to get our blood pressure down. Okay, if that's the limitation of your study, nice job. All right, one of the things mentioned in the manuscript, and I think to their credit, they pointed out, maybe if you know that your barbershop is, participating and they're in the intervention group, is that going to affect who signs up? Is that going to affect who signs up in the control group? If you're a highly motivated patient and you come to your barbershop like, oh, this sounds like a cool study, which one are we in? Oh, we're in the control group. Is that highly motivated patient going to enroll? Potentially not, right? Maybe you lose some of the highly motivated patients, so there's more of those highly motivated patients in the intervention versus the control arm. Perhaps, right? Is that enough to account for 22/15 in blood pressure? We don't know. I don't think we can attribute it all to that, but there could be a role in that.
Yeah. Sean? I think it would have been just as impressive if they didn't even have a control group and they just showed that intervention that they did showed, the blood pressure reduction.
Just versus their own baseline, right? That this is a motivated patient. They don't become motivated overnight. Some of those characteristics were present even before they enrolled, and despite those motivated characteristics, they still had 150/90 baseline. So I don't think this discredits the entire study, but it's take it with a grain of salt. The multifaceted intervention, I think that's what I've really been struggling with is, first of all, the divergent blood pressure goals. When you treat patients to different blood pressure goals, you'll get different outcomes, right? You'll get different blood pressure reductions. The intensity of follow-up or the number of touches. I think there's a lot of literature out there to suggest that the better follow-up patients have, the better they're going to do, right? So I'm not sure how much of this is just related to that having more touches. I honestly don't know. No?
I think that's interesting because when Dave and Evan presented their study at the high blood pressure clinic, one of the things. Go. I think they had twice as many or 3 times as many touches as the physicians.
Or even over a different time frame, right? That the sooner you have those touches, the sooner the blood pressure comes down. Yeah, so I think the number of touches is important. It probably can't just be, obviously it wasn't number of barber touches, right? But maybe the number of provider touches makes a difference. And then the financial patient incentives. One group got a $25 gift card every time. Now, adherence didn't seem to be a problem in the control group. The control group still had over 90% retention. But yeah, you can give me a $25 gift card, I'll do anything you want. $25 each time. Now, they said that this was to offset the cost of the medication. This group was getting more blood pressure medication, so they were trying to, align it with that. But still, it's money in the pocket. It's money in the pocket. And if you want to, put the skeptic's hat on, we only have 6 months follow-up here. How sustainable is this? We don't know. So revisiting the methods. This is kind of, I think I've hit on this a number of times, but there's all these things happening. Do we have to have all of them in place for this to work? Just a few of them? You know, could we pare this down and maybe get a little bit more efficient? Or, I don't know, maybe that's the wrong tack. Maybe we should say, let's keep all of these and let's try to reproduce everything. If we want to have this great blood pressure intervention, maybe we should just keep doing the same thing over and over again. When I went through this, I couldn't help but think about our own local experience that we have at the Center for Healthy Hearts. We have a slightly different practice model. Patients still have to come to clinic over at the Center for Healthy Hearts. We're not going out to them, but it's closer to the community maybe than other settings. We do have a pharmacist-physician collaborative practice model. We are able to initiate medications, do the laboratory follow-up on site. We don't give them $25 gift cards. They don't get free haircuts. We do have a snowball of positive emotion that we create for them. We love on our patients as much as we can. But this was a study that was published earlier this year where we compared our collaborative practice model to patients that basically came through a VCU emergency room. So same city, same general population. And we found that with our collaborative model, we got patients to goal on average within 36 days versus 259 with standard care. And this is where, to your point, we had, by the end of 12 months, the number of visits was pretty similar, but we just had a lot more visits early. So that there was an accelerated number of visits, I would say, versus the total didn't change too much. So I thought, well, what if we plot, our follow-up was 365 days. What if we drew a line at 180 days and we superimposed the barbershop results? It matches up pretty well, which I think is kind of encouraging because it suggests this is, maybe this is reproducible. Maybe we can do this. Maybe if we have the right amount of training and the right type of pharmacist and the right type of access to care, this is something that we could see in both, Southern California and Richmond, East Coast, West Coast. We've got things covered. Now, maybe their control group didn't do as well as our standard of care group, but I mean, it's in the ballpark. We're pretty close. So that was kind of exciting to see that, hey, maybe we are already kind of mass producing some of this. If you want to look, I went ahead and just looked at the average numbers for our patient cohort. From our study, the average age was a little bit younger, but when you look down at the BMI numbers, the smoking, and the diabetes, these are kind of the same patients. I mean, we had both genders, right? We had men and women. Actually, more women, yeah. It was more women in our study. I should know my own paper. More women in our studies. We had a better racial, more diversity. We didn't just have African Americans in our cohort, but this is a similar patient cohort. So it's encouraging. It makes me think, maybe we can reproduce some of this. Going back to the number of medications, one of my favorite blood pressure trials is the SPRINT trial, where patients were randomized to this intensive blood pressure lowering of less than 120/80. The number of medications that the aggressive, intensive blood pressure lowering group had in that trial was 2.8 versus 1.8 in the standard of care group. Again, pretty similar, right? And one of the takes that I always offer on the SPRINT trial is that once you get your patients down to that classic goal of less than 140/90, all of the discussion in the SPRINT trial, you can almost reduce it down to the question of, do I need one more medicine? Because ultimately, that's all you can do. When you have a patient in front of you, you can add a medicine or not. And that's kind of the decision point that you have. And the SPRINT trial would suggest that, hey, if you can safely and appropriately add a medication that they can tolerate, and there's a lot of qualifications there, that patient's going to benefit. And I think this trial, while we don't have outcomes to say these patients did better, we can say that, adding that extra medication at least may be enough to get them to goal in the next 6 months. If we go back to this question of, what's driving the model, is it the number of touches? Is it the vouchers? I'll just put a little plug for our CPPI sponsored study that we're running right now in partnership with Kroger Pharmacy. we're trying to kind of dissect out the drug intervention from the touches intervention. So the study we're doing at Kroger Pharmacy right now is we're giving patients a $10 gift card every time they come in to get their blood pressure checked. No counseling. You can if you want. No formal counseling. There's no counseling script. There's no change in medications that you get. It's just come in, sit down for 10 minutes with your pharmacist twice a month, get your blood pressure checked. We think that will improve adherence. We think there will be some organic counseling that happens just because pharmacists can't help themselves, but you can't help but offer good drug advice, right? When we get a captive audience. So hopefully our study will get a little bit at the question of how much of this is touches, how much of it is just getting patients to get their blood pressure checked, or do you really need to have that drug intervention to see benefit? I think there are a lot of questions they answered with this. It's a huge win, I think, for all parties involved, but still more work to do. But I think that is the end of my slides. So thank you for coming. I'd be happy to sit down and answer any questions.
Was there anything in the discussion about either sustainability or scale up of the barbershop model?
I think that's a great question. The things that I would point to are, first of all, getting pharmacists trained in this type of practice model. And I think we have hundreds, if not thousands, of pharmacists being trained every year to do that. So I think that aspect of it is quite scalable, although they don't really get into that. The study mentioned, it does cite a lot of the literature that's been presented about pharmacist management of hypertension. There are something like 40 studies they reference, or that they allude to, where pharmacists have done this kind of practice. Barry Carter's stuff is probably the most prominent among those. But the pharmacist side of this should be pretty scalable. I think where we need to sort things out is this convenience factor of making it really community-based and making it convenient and reaching out to patients. That, I think that's really at the forefront of where the next studies occur. Patty?
I think actually that's the sense I have where the heart of the problem is. Because when I read this study, what it spoke to me about was what's wrong with primary care. I mean, if you have a control group that cannot do this, that's our standard. And what's driving it not working is the way we pay for it.
And the access to providers. Yeah, exactly.
I mean, it's sort of like you only get 5 minutes of the appointment or 7 minutes. You have no convenience about when you do it, and it's become something that is a barrier to people's. So when I read it, I thought, well, yeah, what's wrong is what we do in primary care. And if we tried to do the same thing in the end with paying for an intervention like this, would it result in the same thing? Where do you put all these constraints around it and it becomes, again, a not usable thing for patients? Because it seems like that's what's happening with primary care so often.
And these are self-imposed barriers. We're doing this to ourselves.
Yeah.
Right, no, I agree. I 100%.
And they are planning a follow-up study, and that will, one of the big issues they're trying to address with that is the scalability aspect of it. And then they're also looking to target more global cardiovascular risk reduction. So maybe even tacking on initiation of statins and other types of preventive therapies. There's momentum again for some of the antihypertensive drugs and even statins to potentially go over the counter for pharmacists prescribing at the FDA. So there's a lot of things I think coming that stems from this work.
I think it's a huge incentive to just, it's a huge incentive to just think outside the box. It's like the genius of the study is, I know, let's go sit in a barbershop and talk to people about their blood pressure. It's ridiculously simple. And it's embarrassing how badly that beat our primary care model, right? There's a part of us that should be embarrassed by that.
Speaking of scalability, I mean, the current way pharmacists are paid, this wouldn't work at all.
This doesn't fit very well in a fee-for-service. Well,
I mean, it could
doesn't necessarily fit in a fee-for-service. Yeah. It would take some creativity to make that work. I think if you, as you kind of expand, make the healthcare system more responsive to performance, right? And you start looking at how to take care of patients as groups, this starts to make more and more sense. But yeah, on that individual encounter-to-encounter basis, I'm not sure how you pay for this. I think you probably could, but yeah.
Can we use this data set to really understand what are the most critical dimensions of this particular sample? Use like a partial least square analysis or some other analogous method?
I would hope we can. I would hope we can. So this was supported by NHLBI.
Okay.
So that means that the data will have to go into BioLink, which means they should be. Don't start yet. I want to do it too. It should be available to us. I haven't seen it in. The last time I checked, it wasn't in there. But they're pretty good about getting these results in there. So
I think it's a year
in a year,
from
yeah.
publication. There's a what's the word? Anyway, there's a hold on it for I think a year before it happens.
I was going to ask, regardless of, I was going to ask this question just because of for academic purposes, but actually identifying the critical dimensions would be interesting to see. They would be interesting to understand what are the changes that we need to really implement in the primary care model. Because if we identify those dimensions in this particular sample, then those, that context can be replicated.
I will say we should try, but I'm a little skeptical because first of all, we had a total of 300 patients, right?
Yes.
And it was a pretty fixed model where I think most of the patients got most of the interventions. So I'm not sure how sensitive this data set's going to be to teasing that out, but it's worth looking. Yeah. All right, guys, I think we're out of time. Thanks again for coming. I'd be happy to stick around and chat for more questions.
Good.